Welcome, everyone. I'm Dr. Amber Hoffman, and I have the pleasure of introducing Dr. Ben Miller for his grand roast this morning. Grand rounds. Dr. Miller is an associate professor of pediatrics at the University of Pittsburgh School of Medicine. He's a native of Western Pennsylvania and earned his bachelor's degree in psychology from Yale University in 1997, graduating magna cum laude with a distinction in the major. He earned his medical doctorate from the University of Pittsburgh School of Medicine in 2004 and completed his pediatric residency training and a year as a chief resident at the UPMC Children's Hospital of Pittsburgh. He joined the Paul C. Gaffney Division of Pediatric Hospital Medicine in 2008, the year that I left. And when I returned in 2023, he had transitioned from chief resident to my boss. During these 15 years, he served as an associate director of the pediatric residency program from 2014 to 2024. He's served as the division director of the Paul C. Gaffney Division of Pediatric Hospital Medicine since 2017, and this division has grown to over 30 faculty members. Dr. Miller's academic efforts are focused on medical education, research, the PHM workforce, and physician well-being. He's presented numerous abstracts and workshops at national meetings, and he has been an invited speaker at regional and national meetings, as well as for U.S. residency programs and PHM divisions. He currently serves on the editorial board of the American Academy of Pediatrics Prep for Hospital Medicine. He was recently appointed to the board of directors of the Ronald McDonald House Charities of Pittsburgh and Morgantown. Dr. Miller has also been coordinating the care of children of the Pittsburgh Steelers, players, and coaches and staff since 2015 as the team pediatrician. It has been a true joy to have worked with him as a medical student to the accomplished leader he is today. Faculty, please be nice to your medical students, for they may someday be your boss. Please join me in welcoming Dr. Ben Miller.
Good morning, everyone. Thank you, Amber. That was a wonderful introduction as expected. I'm really honored to be here and really excited to present this today. Many thanks to Noelle Spears, who couldn't be here today, but for inviting me to give this talk. It was a great catalyst for me to put this project into fruition and work with some fantastic colleagues to move this project, which I've been very passionate about, forward over the last couple of years. We're going to jump right into the talk. I have no financial disclosures. I do want to mention, however, that we're not going to talk politics today. This topic, certainly about learned helplessness and feeling like we might be powerless against some forces that are acting on us, certainly can bend itself into a political conversation. We had a wonderful talk on politics last week from Dr. Annie Andrews for Grand Rounds, and that would take up an entirely different talk. So we're not going to go into that realm today, but please know that I recognize that, but just this outside the scope of today. I also want to mention that we're going to talk about some psychological studies that took place in the 1960s, and some of this by today's standards is going to sound pretty harsh and maybe a little bit offensive, but I'll remind people that this was a different era. The institutional review boards did not exist back then. They didn't exist until the National Research Act in 1974. PETA wasn't formed until 1980, and the ASPCA didn't have a whole lot of power back then. So to sort of paraphrase one of my favorite TV shows, this was the 60s, man, as Bandit might say. If you haven't seen an episode of Bluey, I highly recommend it. So here's our agenda for today. We're going to start with an introduction, a little bit on my path and how we got started here. We're going to spend some time talking about the power of the situation, how our environment can really shape attitudes and behavior. We're then going to go around that loop and talk about learned helplessness as a concept. We're going to briefly talk about physician burnout as a concept and really focus a lot of time on the intersection between those two things. And then veer a little bit into positive psychology and some of the work that's been done, or some of the theoretical work at least that's been done in that realm. And then try to put it all together and talk about future directions and how we can maybe help institute some change towards the betterment of our profession. And then, like any good story, there is a twist at the end. So I want to keep everybody's attention to let you know that at the end, you'll see a little bit of a twist. Whoops. So an introduction. So this story for me, and then, of course, for you, began in the fall of 1994. It was my sophomore year at Yale, and I signed up for the Introduction to Psychology class, and that was taught by Dr. Peter Salovey. Peter Salovey at that time was an associate professor of psychology, and he was a beloved teacher. He was beloved because he was an excellent teacher and also because he had a bit of a reputation as a lenient grader. He was known as Easy A Salovey. And and he then actually went on to become president of Yale University very deservingly from 2013 to 2024. And he has no idea who I am. I can't say he's a mentor of mine. I was in a classroom of 300 people, but he was hugely instrumental in how I think about topics, how I think about psychology actually is what encouraged me to go into psychology as my major. And so just a little bit of a side note or maybe micro lesson is that you never know what impact you might have on other people as an educator like Dr. Salovey had on me. And the big takeaway from this class that we had, this Introduction to Psychology class, was the power of the situation. That our environment plays a huge role in not just forming what's around us, but forming what's inside of us. So it has a huge role in forming attitude and behavior. And some classic examples from psychology here include what's known as the Robbers Cave experiments. This is back in the 1950s. An investigator named Dr. Sharif had 8 to 10-year-old boys, and they placed them in 2 different groups at a summer camp. They didn't know the other groups existed at first, and these separate groups of boys developed their own hierarchy, social structure. They played games, they had fun, and these kind of developed little societies. And then they introduced them to the presence of the other group and started having them compete in different games and different situations. And they quickly developed animosity towards the other group. And this really kind of showed that the situation played a really large role in how they felt about each other. They didn't know these other kids. They just knew them as other. And by that token, didn't like those kids. And then Dr. Sharif put them into a collaborative situation where the 2 groups had to work together to solve a problem. And the only way they could solve this problem was by working together. And lo and behold, they started liking each other. They started getting along. So it really shows the power of the situation. It wasn't about who these kids were. It was just about the fact that they were in different groups. They were in these artificially different groups, and that really had a huge impact on their attitude and their behavior. Another classic example is the Milgram shock box experiment from the 1960s. This took place at Yale. Not so proud of this one, but this one, Dr. Milgram had subjects, these were mostly undergraduates, and they were put in a situation where they were supposed to administer a test to another person. What they didn't know is this other person was actually Confederate. They were part of the study. And every time the person in the study, the Confederate, got a question wrong, the subject was supposed to deliver an electric shock to this person. And they had someone else standing over their shoulder, also a Confederate in the study, who was the authority figure, would tell them to keep going and keep shocking, even when the Confederate was begging them to stop. And most people did this. They continued to shock the other person, or at least they thought they were shocking, they weren't actually shocking them, just because of the situation. The power of that authority figure standing over their shoulder demanded they continue to do it, so they continued to do it, even though it was against their own morals. They continued to do that. Again, the power of the situation. And probably the most famous example is the Stanford prison experiment. This happened in the early 1970s at, of course, Stanford. And the main investigator, Philip Zimbardo, took 24 undergraduate men, and put them into 2 groups of 12 and said, this group of 12, you are the prison guards, and this group of 12, you are the prisoners. And they converted the bottom floor of one of their administrative buildings into a fake prison. And that was basically it. They just set up this situation and watched what these people did. And this study was designed to take place over 2 weeks. After 6 days, they had to stop the study because it was so emotionally damaging to the participants on both sides, both the guards and the prisoners. This is just a pure hypothetical or a created situation that caused significant distress on these people. So again, it speaks very much to the power of the situation. It is incredibly influential in how we think, how we behave, and how we create our attitudes about things. So I'm going to flash forward now to an early part of my career with some of this background. I'm sitting in a meeting over in the other part of Rango's, and this is a physician leadership meeting. And at that time, our VPMA, is not our current VPMA, was delivering a talk and started talking a little bit about physician wellness. And the VPMA shared this slide, and I apologize it's blurry, but this was taken from a cell phone photo. And the details here aren't important, but what the VPMA said was, this is a pie chart of all the things that contribute to physician burnout. These are the individual physician factors, about 20%. These are the institutional factors, about 80%. And he even quoted the author of this is actually unpublished, but the author here, Colin West of the Mayo Clinic, who's done tons of work in physician burnout, who said, there's broad agreement that causes of burnout are about 80% organizational and 20% individual. And our VPMA, after talking about all this, said, okay, here's our opportunity. This is our area of focus. Let's help the doctors get better. And I turned to my colleague sitting beside me, who was one of my dear friends and mentors, Dina Hofkosh, and I said, did he really just say that we're going to focus on the 20% and not the 80%? And she said, yes, Cookie, that's exactly what he said. And so I was just baffled by this, that a very smart, emotionally intelligent person was looking at this information and saying, the 20% is our opportunity, when I think the 80% is probably at least as big of an opportunity. And I started thinking more about this. Why does this happen? Why do we think only about what we can control? Why don't we start thinking about the organization? And I thought this probably goes back to another lesson I learned in psychology, learned helplessness. And we'll talk a lot more about this in detail when I talk about some of the people who brought this along. So two psychologists who were at the time practicing or teaching at the University of Pennsylvania, Martin Seligman and Stephen Meyer. And they did experiments back in the 1960s. And probably the most famous experiment they did in this topic was the Shuttle Box. So in this experiment, they had this box that had this small partition in the middle, and they would place a dog on one side of the partition or one side of the box that on the floor could deliver an electric shock to that dog. And as Dr. Seligman wrote, the dog would, quote, run frantically about, defecating, urinating, and howling until it accidentally scrambles over the barrier and so escapes the shock. And they would put the dog back in the shuttle box, and the next time it would learn much more quickly to jump over the partition, until eventually put that dog in the shuttle box, and even before they delivered the shock, the dog would jump over to the other side. So these dogs relatively quickly learned that they could escape this shock. And in fact, 94% of dogs in this situation learn to escape quickly. But they wondered what happens if we teach dogs they can't escape, or at least try to condition them to think they can escape. So what they did was they placed these dogs in what was called a Pavlovian harness. And small disclosure, that's not a Pavlovian harness. That's just a grooming device from Amazon. I had to take some creative license in my photographs, so I couldn't find a photograph of a Pavlovian harness. But it's the situation where the dogs are placed in this harness and they were delivered an electric shock that they could not control. And it was a constant electric shock. And they even actually placed some devices around some of these dogs. The dogs thought maybe if they could put a paw on something or touch their nose to something, maybe they could stop the shock, but the shock would not stop. They purposely made it an uncontrollable shock. And then they placed these dogs in the shuttle box and watched what happened. And only 33% of these dogs ever learned to escape. Most of them just cowered in the corner and took the shock. And the ones that did learn to escape, it took them a very long time to learn how to do that, much longer than the dogs who had never experienced inescapable shock. And so what they came up with was this concept of learned helplessness, which is a psychological state affecting an individual who repeatedly faces negative, uncontrollable situations and comes to believe they have no control over their environment. And as Dr. Seligman later put it pretty succinctly, this is an interference with adaptive responding. And a couple other psychologists wrote later, the perception of response outcome independence, there's no relation between response and outcome, generates a sense of uncontrollability, and the perceived uncontrollability prevents animals and humans from actively coping in a new stressful situation. This is this concept of learned helplessness. And they went on to study this in different species and found this is a very reproducible phenomenon. They studied it in rats and mice. They studied it in cats. They studied it in fish. I didn't read about that one. I'm not sure how they did it in fish, but they studied it in fish. They studied it in humans, or at least undergraduates. And this has been shown to have a durable effect on learning, affect, and behavior. So learned helplessness is not benign. This is actually a pretty significant impact on how people function and how species function. And they started thinking about learned helplessness as a model for depression. One of the reasons they found this, there was a link here, is because it's reproducible. Within humans, within other species, this is a reproducible phenomenon. There are also similar symptoms between learned helplessness and depression. Here's an example from the early 80s. The lack of incentive to respond in the face of stress, as well as the failure to learn from successful responding in helpless animals, mimics the motivational state and negative cognitive set observed in many depressives. It's also shown that helpless animals have a drop in brain norepinephrine. And if they were to give classic antidepressants to either the animals or humans in these situations, it would mitigate the effects of inescapable negative stimuli. So it was pretty well agreed upon in the 1980s that learned helplessness could serve as a good model for at least one pathway towards depression in people. And Dr. Seligman went a little bit farther to look at other things that may influence this. And he looked at what we call attributional style and how this can impact learned helplessness. There are three different axes, if you will, for this attributional style. One is stable and unstable. Is this something that is always there, stable, or something that might be more malleable and unstable? Is this, the other axis is global and specific. Is this in every situation, or is it specific to only certain situations? And lastly, the other axis is internal or external. Is this about me, or is this more about my environment or the world around me? And what Dr. Seligman would say is that if you find yourself in that corner of the rectangle, if you take these three axes and have them intersect, in that back corner, if you think about this rectangle in 3 dimensions, where things are stable, global, and internal. So this is not malleable, this is in every task, and this is about me, those people are very high risk for learned helplessness, and then very high risk for depression. If you think about people up closer to that green dot and that other part of the rectangle, the part maybe closest to us, if you think about this in 3 dimensions, where things are unstable, more malleable, they are specific to a task and not global, and they are more external, more about things out there than about me, those people are at much lower risk to experience learned helplessness, and by extension, maybe a little less likely to experience depression. And Dr. Seligman and his colleagues said, the attribution chosen influences whether expectation of future helplessness will be chronic or acute, broad or narrow, and whether helplessness will lower self-esteem or not. And I want to think about that word chosen, because we're going to come back to that a little bit later on. We'll come back to this concept a little bit later on. We're going to pivot now to talk a little bit about burnout. And many of you probably know that Christina Maslach is really the pioneer in this field. She developed what's now known as the Maslach Burnout Inventory. You've probably all taken one of those at some point in your life. We give them to our residents here every 6 months as a nice screening tool for burnout. And it's really kind of agreed upon. That's the gold standard as a screening tool for burnout. Interestingly, Dr. Maslach was at the time an assistant professor and then went on to become a professor at Stanford. And she was part of the ethics committee that stopped the Stanford prison study 6 days in and didn't let it finish all the way. And then interestingly, she went on to marry the PI of that study, Philip Zimbardo, and they lived a very happy life together. So, you know, psychologists, what do you know? But her work really led to us understanding burnout as a work-associated syndrome related to chronic stress and emotionally intense work demands with inadequate coping resources, characterized by 3 things: emotional exhaustion, depersonalization, and a lack of a sense of accomplishment. And I love this quote. They say, burnout is an apt term suggesting a once hot fire that has been reduced to ashes. But I think it's important to note that burnout is not the same thing as depression. So burnout is defined as the WHO as an occupational phenomenon that deserves attention, but not classified as a medical condition. And the American Psychiatric Association does not include this in the DSM. And they say burnout is inherent to the human condition, which is probably an unfortunate reality. It's also worth noting that studies show that about 40 to 70% of physicians experience burnout at the given time of that study. So this is a pretty common phenomenon, particularly in our field. Whereas depression is a mood disorder that causes persistent feelings of sadness and or a loss of interest. It is, of course, listed in the DSM-5 and has diagnostic criteria. And the annual prevalence is estimated to be about 7%, but that is probably a gross underestimate because so many people don't seek care when they truly would meet criteria for the diagnosis of major depressive disorder. So we've talked about learned helplessness and the fact that it's linked to depression. We've talked about burnout and said the burnout is not necessarily the same thing as depression. What about this area where we look at the intersection between learned helplessness and burnout? This actually has not been studied specifically in our profession or any other that I could really find. So this is the area I wanted to focus on. Is there an element of learned helplessness in what we do? And is that associated with burnout? So the way we went about doing this is by starting with what's called the Mini-Z 2.0. This is part of a movement in the early 2000s called the Zero Burnout Initiative. That's where the Z comes from. And this has 9 items about medical workplace environment and experiences. And these are all on a Likert scale, or Likert, as Andy knows. And this correlates really well with the MBI. It's been validated and has good correlation. There are a couple of questions in the Mini-Z that talk specifically about the EMR, the electronic medical record or electronic health record. Those don't correlate as well with the MBI, but everything else correlates pretty well. And the Mini-Z also has one question specifically about burnout, and I'll show you that here in just a second. And this one question has been validated against the entire 22-item MBI with pretty good correlation, specifically for the emotional exhaustion subscale. The score range in the Mini-Z is between 10 and 50, and the authors say that a score greater than or equal to 40 indicates, quote, a joyful workplace. So here's the single question burnout item, number 5 on the scale that says, I enjoy my work, I have no symptoms of burnout. Number 4 is, I'm under stress and don't always have as much energy as I did, but I don't feel burnt out. 3, I'm beginning to burn out and have 1 or more symptoms of burnout, for example, emotional exhaustion. 2, the symptoms of burnout that I'm experiencing won't go away. I think about work frustrations a lot. Or 1, I feel completely burned out. I'm at the point where I may need to seek help. And the authors of the Mini-Z, and we included this in our study, have an asterisk beside 2 and 1, encouraging people to think about seeking help through their employee assistance program. And the first 2 items there, 5 and 4, are considered for statistical purposes and for analysis, considered not burnt out at all, whereas 1, 2, and 3, as you can see from the language there, have some element of burnout. So we often are going to put those into 2 separate groups. And then we're going to think about learned helplessness. And so we looked to try to find a scale for learned helplessness that we could try to measure. And one didn't really exist, particularly in the field of medicine. There are a couple of scales for learned helplessness that didn't feel that applicable to what we were trying to study. So I assembled a research team, which includes Dr. Romito, a former colleague of ours, Dr. Kristen McDermott, who is both a pediatric hospitalist and a child and adolescent psychiatrist who's currently at Connecticut Children's, and then a PhD researcher, Dr. Paige Zalman from Carnegie Mellon. And our team put our heads together, and we came up with a novel learned helplessness scale. So this has 12 Likert-style questions, 6 with a negative skew, 6 with a positive skew. A higher score on this scale indicates less likelihood of learned helplessness, and the score ranges between 12 and 60, and then we included 4 open-ended questions. Here are the quote-unquote negative skewed questions from that. I feel trapped in my current job. I've learned to accept the less appealing aspects of my job. I feel beat down by the number of demands from my leaders. I find it challenging to feel a sense of accomplishment at the end of the workday. I am lonely and isolated when at work. I feel helpless about the challenges I face in my work. And this was scored on a 5-point scale, with strongly disagree being a 5, because if you disagree with these statements, that was more positive. So strongly disagree is a 5, all the way down to strongly agree as a 1. And we have positive questions like, I have a sense of autonomy in my work. I have control over factors that affect my stress level at work. When I encounter an obstacle in my optimal functioning at work, I am energized to overcome it. I have agency and my actions can positively affect my work environment. I feel connected to people at my workplace. My job brings me a high level of joy. And this had a 5-point scale where strongly agree is 5 points, because again, these are positively skewed. So we launched our pilot learned helplessness study. This was conducted in late May and early June of this year. It was a questionnaire in Qualtrics. We had the learned helplessness scale that we developed plus the Mini-Z 2.0, and we also included some demographic questions. We emailed a link to all physician members of the Department of Pediatrics affiliated with UPMC Children's Hospital. That includes physicians who practice here in Pittsburgh, but also at any of our outlying sites who are members of the Department of Pediatrics. And also all the physicians in the Pennsylvania Pediatric Health Network, or PPHN. These are primary care physicians at Children's Community Practice, AHN Pediatrics, Kids Plus, and a few other practices in the region. And you see we had 334 physicians from the DOP and 272 physicians in the PPHN. This was approved by Dr. Dermody as the chair of Department of Pediatrics and by the physicians and the executive and research directors of the PPHN, and this was deemed IRB exempt. So to show you some demographics of our respondents, of note, we considered someone to be a respondent if they completed all the questions of both the learned helplessness scale and the Mini-Z 2.0. There were some people who completed those but did not complete all the demographic questions. We still included their answers on the learned helplessness scale and the Mini-Z 2.0 as part of our analysis of those two measures, but did not include those, of course, in the demographic measures. So we had a 20% response rate, which was somewhat low, unfortunately. But for those 121, especially the 95 people from the Department of Pediatrics, we're very appreciative of your participation. As pediatrics is in general, this was skewed towards females, with 72% female. This was pretty evenly distributed between people in early, mid, and late career in their years since completing their training. Most people were in the first 10 years in their current job, whereas about 13% were in their current job for more than 20 years. We also wanted to look at potentially marginalized characteristics. Our theory was that potentially people who have experienced marginalization, things like underrepresented minorities in medicine or first-generation college students, they might have experienced learned helplessness in their lives a little bit differently because they've had more constant stress that they've had to overcome. So we wanted to look at this, and this was a choose all that apply kind of question. And it was about half and half between people who identified 0 from this list or people who identified 1 or more of these potentially marginalized characteristics. And then we also want to look at leadership. Do people in roles of leadership experience learned helplessness differently from other people? And so we asked people, are you a current leadership role, former, or none? And about 3/4 of our respondents had either a current or former leadership role. Our scale results from the learned helplessness scale had a mean of 39.86 with a standard deviation of 8.86. And really importantly, looking at the ranges here for both scales, we saw really everything pretty much across the board. These are not necessarily normally distributed across this entire scale, but on both the learned helplessness and the Mini-Z, we saw things really on the very low end of the scale and almost all the way at the top end of the scale. When we look at the frequency of burnout, we look at it by how people respond to that one item question, where they gave a 1, 2, 3, 4, or 5. We start sort of at 12 o'clock on this pie graph and go around clockwise. That's 1, 2, 3, 4, and 5. And as I mentioned, most of the time we're going to analyze these by grouping 1 through 3 together and 4 and 5 together. So in our sample, 46% of respondents answered either a 1, 2, or a 3, meaning they were experiencing some element of burnout. And as we talked about, this unfortunately does match pretty commonly with a lot of the studies that are out there, that about 40 to 50% of physicians are experiencing burnout. We also want to look at this term, the joyful workplace. So this is, again, if someone scored a 40 or greater on the Mini-Z, they were considered to be a joyful workplace. 5.8% of our respondents would qualify for a joyful workplace by scoring 40 or greater on there, which is not high for those of you who are not quick at math. And interestingly, one of the very few statistically significant findings between groups was that people in the academic group were statistically significantly much less likely to score as a joyful workplace than those who work in the community. For this analysis, we grouped academic subspecialty and academic primary care together, along with community subspecialty and community primary care. We also wanted to look at other demographic characteristics and see how they might compare with these 4 major measures that we looked at: the single question burnout response, that 1 through 5, the learned helplessness scale score, the mini-Z 2.0, and whether or not on the mini-Z they would scale in a joyful workplace. That's pretty dichotomous, yes or no, joyful workplace or not. And we analyzed these with all of these different demographic characteristics, 1-to-1, and we found there's actually no statistically significant difference between any of these groups. Now, I mentioned that a multivariate analysis is pending. We are working with some statisticians to do a little more work on this, so we might have some more information, for example, some combinations of these things, or maybe there are certain responses to the marginalized characteristics that might bear out to be statistically significant, but as of right now, we didn't find any differences in those groups. However, we did find something I think very interesting and noteworthy, and that is when we correlate the learned helplessness scale with the mini-Z, there's a very strong correlation. So in this graph, the mini-Z is the x-axis, the learned helplessness scale is the x-axis, the mini-Z is the y-axis, and the correlation here, the Spearman's coefficient, is 0.617. And in social sciences research, anything 0.5 or greater is considered a pretty significant correlation between those two things. And so this does seem that our novel mini-Z scale links pretty well to our novel learned helplessness scale links pretty well to the mini-Z. When we look at this on the single item burnout question and group those people who answered 1 through 3, they're experiencing burnout, and those who are 4 through 5 not experiencing burnout, those two groups have a statistically significant difference in how they responded to the learned helplessness scale. You can see there's no crossover here between the 95% confidence intervals, and also the two-sample t-test had a p-value of less than 0.0001. It was actually 0.1 something to the 10 to the minus 14th. So really a statistically significant difference here. And so what this, I think, clearly shows to us, at least at this point, is that learned helplessness does correlate with burnout. Now, we can't say anything about causation. We need to do a lot more work to talk about causation, but we can say there's a correlation between learned helplessness and burnout. And you may be asking yourselves, like we were asking ourselves at one point, are these two scales just measuring the same thing? So did we just ask the same question in a different way, and that's why these scales correlate? And so we wanted to look at that in a little more detail. So again, this is the correlation coefficient for our learned helplessness scale when compared to the mini-Z. We broke down our learned helplessness scale into the positively skewed questions and the negatively skewed questions. We still saw pretty good correlation there, but not as strong as we did the entire scale. So that really tells us there is some worth in using the entire scale when we compare it to the mini-Z. And we noticed there are a few questions that we had developed in the learned helplessness scale that talked about agency or control or autonomy. And there's one question in the mini-Z that talked about control. And so we looked at these specific questions and tried to correlate individuals' answers to those questions with their answer on the question about control to mini-Z. And you see there's a much, much weaker correlation here. And so what this tells me is this is not just asking the same questions. This is really a novel scale that we can use to say there is correlation here, and this maybe stands on its own. A lot more work needs to be done to validate this scale, but early on, this shows some promise, in my opinion. So now we're going to move a little bit farther along in our journey. I want to focus a little bit on positive psychology. So now that we've established that learned helplessness is related to burnout, we're going to talk about positive psychology and what are maybe some ways we can combat this. And we're going to come back to this guy. So Martin Seligman had a really interesting turn about halfway through his career. We stopped working with dogs and looking at learned helplessness and started thinking about positive psychology. And in fact, he was elected president of the American Psychological Association in 1998. And he used his inaugural address at that meeting to talk about shifting the focus of the APA a little bit away from pathology and a little bit more towards beneficial factors. What are some protective factors that we can provide to people to prevent pathology from happening? And so he is largely known as the father of positive psychology. So really kind of a fun and interesting turn in his career. And so he developed what's known as the PERMA model for positive psychology. And this includes positive emotion, engagement, relationships, meaning, and accomplishments. And you see these all have pretty positive connotations. And you can probably relatively easily see how these things are linked to feeling better, feeling more positive for the vast majority of people. And when studied, at least a pretty comprehensive study from about 11 years ago, these 5 features were positively associated with physical health, vitality, job satisfaction, life satisfaction, and organizational commitment. So it's in the organization's best interest to think about positive psychology and how this plays a role. And you guys probably have seen some of the My Voice survey results that we do here, and they often stratify people based on engagement. This is what we're talking about. We're talking about this level of engagement. So thinking about positive psychology can really have a huge impact on an organization, how people feel about the organization they work for. And I think a fantastic example of this is the Thank Yous program. If you're not familiar with this has been around now for about 4 or 5 years. This was helmed by Dr. Marin Leno from the the Office of Faculty Affairs. She worked with the other members of that group to get a Physician Thrive grant. And the Thank Yous program is online, where you can go and you can just deliver a thank yins. So those new to Pittsburgh, yins is a Pittsburgh thing. It means you. That's a whole other talk. But basically, you can congratulate somebody for work well done, and this gets noticed by an email to the division director, and also you get like a $5 Starbucks gift card. And that part is nice, but really, the Thank Yous program is engaging in all 5 aspects of the PERMA model. There's positive emotion here, there's engagement with somebody else, there's talking about relationships, there's meaning behind it, and it's celebrating accomplishments. So this is a fantastic example of something happening here that really is applying positive psychology. And then to talk a little bit about self-determination theory. Richard Ryan and Edward Deci back in the 1980s developed this theory of self-determination, which talks about how we become more fully, wholly ourselves. And there are 3 elements to that. There's autonomy, competence, and belongingness. And when people experience all 3 of these things, they are much more likely to feel whole and be able to feel a sense of connectedness and feel like they have agency, determination in their life. So we're going to come back to these a little bit later, especially as we go through and talk about the analysis of our qualitative aspect of our study. So just a little bit about some of the details of our qualitative analysis. We use an inductive approach, which means that we did not preset any categories from the answers that we received. We inductively created these as we went along and did our analysis. This was done by 3 independent coders, Dr. Ali Ramito, Dr. Paige Zalman, and myself. We coded about 50 to 75 responses in each category and then met to agree on a universal code book. We applied that code book independently to each of the remaining responses in all 3 of the main open-ended questions, and then we discussed discrepancies until agreement was attained. And in that analysis, we looked at these 4 questions. List up to 3 strengths you possess that help you to succeed in your job. List up to 3 stressors you experience due to your work. List up to 3 strategies you have tried to address this stress. And have you found these strategies successful? Why or why not? So in that first question, 3 strengths, we had 97 respondents to this question, providing us with 285 strengths. 3 were unique or not codable, so we didn't include those in our analysis here. So the other 282 are included. And you can see things like emotional and attitudinal traits like positivity, resilience is a very common response, even-keeled, compassionate, calm. Those made up 84 or 29% of those responses. Motivational traits, like I derive a lot of pleasure from the purpose I have here my desire to help others. We categorize that as motivational. Cognitive processing is divergent thinking, open-mindedness, adaptability. We had some acquired skills like experience, wisdom, communication skills, organizational skills, factors of the workplace environment like mentors or colleagues, and then personal life supports. And just provide a few sample quotes here. One, I'm good at compartmentalizing frustrations with our administration to enjoy my patient care. This we thought was a cognitive processing, that compartmentalization. I have perseverance and dedication to patient care that allows me to show up every day and do hard work. That's a motivational trait. Or I have genuine joy with helping patients and families solve concrete problems. The next open-ended question we asked was list 3 stresses you experience. We had 99 respondents to this question who offered us 273 strengths. 9 were unique or not quite codable. And so we ended up analyzing the other 264. And we also put these into 7 different categories. The non-clinical workload, things like an administrative burden, teaching burden, academic productivity, any kind of pressures or conflict with administration, all fall into that category. The clinical workload, which also included documentation or stressors with patients and families, under-resourced, meaning time, funding, or staff, feeling undervalued, conflicts with colleagues, personal life, or we had a few people who give pretty short or vague responses that we felt were tied to the workload, but couldn't decide if that was clinical or non-clinical. So we had this sort of other category. If you put all those together, that bottom category in the first 2, you see that overwhelmingly the stressors involve the workload that people experience. And some sample quotes here include added work demands without personal involvement in the decision process, which is a non-clinical work demand. Not everyone on the team is aligned with the mission, maybe a little bit about colleagues. And there's almost constant change and no time to adapt. So that non-clinical work demand. And then our last big open-ended question was list up to 3 strategies you've tried to address this stress. We were able to put this into 4 different categories. And we had 235 strategies presented to us with 8 unique or not codable. And the most common was what we categorize as behavioral management by engaging more. This is sort of leaning in. So this is devising dot phrases in the EMR, or this is more prioritization or efficiency, finding out ways, maybe sometimes engagement with administration to try to fix some problems. That's sort of leaning in. Cognitive emotional strategies like acceptance, just stay positive, reframing the perspective. Personal wellness, like focusing on mindfulness. We have several people talking about being engaged in therapy. Those are some examples there. And then behavior management by engaging less. People who are leaning out. So people who are delegating more things, establishing more boundaries, people who are reducing their FTE or actually looking for jobs elsewhere. Those were what we put in that final category. And here's some sample quotes. Keeping my values in the center of my actions and following my own North Star and try to change the things I am in control and let go of the things I cannot control. This is sort of a cognitive emotional strategy. Contribute to collegial and caring atmosphere as much as I can. Be kind, bring treats, show others that I care. That's another cognitive emotional connectedness strategy. And then identifying and advocating with administrators that are committed to the care of people. So this is an example of sort of leaning in, that behavior management by engaging more. And we look at these by the 10th question on our sample, the 4th open-ended question, are these successful? Why or why not? And we found that overall, people said about 54% of the time their strategies were successful. And the most common successful category were the cognitive or emotional different responses that people had. And unfortunately, the least successful seemed to be that leaning in or engaging more. We did a little bit further analysis and found something very interesting. And this is the influence of burnout on the success of these strategies. So remember that a 5 and 4 on that single item burnout question would indicate you are not experiencing burnout. And when those people gave us these stressors in their strategies and then said whether they're successful, 58, 59% of the time, their strategies were successful. The people who had one element of burnout, answer to 3, also pretty successful in their ability to develop strategies to deal with stressors. People who answered a 1 or 2 on the burnout scale had almost no ability to develop successful strategies to deal with stress. Only 4 out of those 32 responses gave us something they said, this is successful, this is working for me. So we're going to come back to this a little bit later on, but I think there's a lot here that hopefully can help us as we move forward. Speaking of moving forward, we're going to talk about some future directions and where this might go. And I actually want to categorize this into three main buckets here: the role of administration, the role of individuals, and the role of us as a community. And by us, I don't just mean the people in this room or the people online. I mean the medical community. And by administration, I don't just mean the people on the 6th floor of the AOB right now. I mean administration in general. That can include me as someone in middle management, as a division director. That includes a lot of different people in a lot of different roles. And we're going to incorporate some quotes that we brought in earlier to talk about how this might play out. So one quote I really liked that we talked about earlier: identifying and advocating with administrators that are committed to the care of people, and not everybody on the team is aligned with the mission. So I think a very, very important component here is that physicians and administration develop a shared understanding about burnout and about learned helplessness and a shared concern. I'll share a quick anecdote with you guys. A couple of years ago, I was in a meeting with a relatively high-ranking administrator in the UPMC system, and I was expressing concern about burnout in physicians and in nurses. And this administrator replied to me, "Burnout is just an excuse." That's not a shared understanding of burnout. And so I think this is imperative as we think about this to bring this together and to understand this and have a shared concern. Shared accountability, I think, is also really important. There's an excellent, and I think a very important new concept: administrative harm. And there's a really nice article from the New England Journal from a couple of years ago by Dr. Walter O'Donnell that laid this out, I think, in a really, really nice anecdote. He talked about this administrative harm he experienced with a patient where they had a Dr. O'Donnell practices adult medicine. They had a smoking cessation program in their hospital that was cut, just didn't make it in the budget. So that program was cut. And because of that, one of his patients was no longer a candidate for transplant because this patient was in that program for smoking cessation. The program was cut, went back to smoking, was actually getting some success, went back to smoking, was no longer a transplant candidate, and ended up dying. And Dr. O'Donnell said, this is administrative harm. This is decisions by administrators that ends up harming people. And it doesn't take a whole lot of common sense to understand that this link happens. And so he also brought up some other very good points, I think, too. Surgical outcomes are available publicly by surgeon. You can look up a surgeon and find out what their surgical outcomes are on the internet. Press Ganey scores, patient satisfaction scores, particularly people who practice outpatient medicine, are available on the internet. UPMC posts them on our website. We can go and look at any individual's patient satisfaction scores. But administrators don't have that same kind of thing. When our asthma educator program here was cut several years ago, it was just cut. There was no announcement. There was no owning of that program being cut. It was just cut. And so I think what we need to start moving towards is more transparency and ownership of this administrative harm. I think we also need to look at reducing administrative bloat. So this is a paper from just a couple of years ago. And it's actually written by people who work for McKinsey Group. Those of you who are familiar with McKinsey Group know they are a consulting firm. There's one physician on here, but they're a consulting firm who helps healthcare organizations manage their funding. And they looked back at 2019 and found that $3.8 trillion were spent on the US healthcare, and almost exactly a quarter of that on administrative functions. And they looked at the ratio of administrators to frontline workers. And in other sort of quote unquote white collar industries like the legal industry, education, commodities brokers, administrators to frontline people is about 0.85 to 1. In medicine, we consider frontline workers to be physicians and nurses. That ratio is 2 to 1. So there is clearly administrative bloat in our system. And it doesn't take too much deep thinking to understand why, because administrators are the ones who decide who's getting hired and where all the money goes. So one thing I've been speculating is, do we need more physicians in the roles of administrators? Is there benefit to having physician or clinician, nurses, for example, CEOs? This has not been well studied. There was one study published a few years ago that looked at comparing hospitals with physician CEOs to hospitals with non-physician CEOs. And the only statistically significant difference there was in patient satisfaction scores. Actually, the patient satisfaction scores in the physician CEO organizations were higher than the other organizations, but there was no difference in physician burnout and other factors. Patient safety, no other factors they studied were really different. But I think this is an area we can look into further to try to help mitigate some of these things that we're experiencing as physicians. Another quote that came up was these added work demands without personal involvement in the decision-making process. And so I think it's really important that administrators involve physicians in decision-making. This goes back to that autonomy from self-determination theory. When we have that autonomy, we have some control, we can feel more whole. We can feel more like whole people. Also reminds me of a quote from one of our former CEOs here, Chris Gessner, who used to say, "Don't go to physicians with solutions. Go to physicians with problems and have them work with you to find solutions." I think that's really good advice, and that's what a lot more administrators in healthcare, I think, should take that approach. Another quote was, "There's almost always constant change and no time to adapt." So I would say that a good administrator should try to provide some stability. This sort of sometimes month-by-month response to patient satisfaction scores or month-by-month response to budget reports is probably just too much seesawing. Let's take a little bit more time. Let's see how things bear out over time and maybe practice a little bit more stability there. And then try to be cognizant of constant demands. When one initiative finishes, let's celebrate that one before we move on to the next one. Or let's not stack these initiatives. It also kind of goes back to that not seesawing back and forth so frequently. And I think a great biological example here, or at least one that was studied in animals, is going back to Seligman's early work when he did work with rats. And this is a little bit harsh, but they would take rats and squeeze these rats until the rats stopped fighting. And once the rats gave up, they'd put the rats into a bucket, and within 30 minutes, the rats would drown. However, if they took rats and squeezed them and then relaxed, and then squeezed them and then relaxed, ended up squeezing those rats for the same total duration of time as the other rats, and then put them in the bucket, they would survive. They'd swim for 60 hours. So I think that demonstrates that as biological species, we need breaks. We need time to recover. We need to understand that we don't just always have these constant pressures on us. What are some roles of individuals? So one thing I think is to establish realistic goals. Medicine is really hard. There's no questioning that. Give yourself some grace. Don't always put so much pressure on yourself to meet every goal, to teach every student, to have the best note every time you see every patient. Give yourself a little bit of grace there. And also recognize that total autonomy is probably not realistic in today's healthcare environment. Those of us who work in academic medicine, even those people out in a community site, almost always have other things you need to answer to. And so I think to have this notion that complete autonomy is something that is attainable is probably not setting a realistic goal. The other thing worth mentioning is cognitive behavioral therapy. This has been shown to improve learned helplessness, and as probably all of you know, has also been shown to improve depression. And I think UPMC does a really nice job of offering some resources here. They have Life Solutions. They have the Curbside program. I found my therapist through Curbside and had a great relationship with her over the last 2.5 years. So I think it's a really wonderful program. Also think about reflecting on your attributional style. So going back to this rectangle, do you find yourself more in the stable, global, and internal place where you're more susceptible to learned helplessness, or more on the outer part of that rectangle? Maintaining competence, going back to self-determination theory. When we feel competent in our job, we're going to feel more like whole people. So staying up with literature, making sure that you are doing the best work that you can with some of that grace. And also note that competence was a frequently cited strength in our earlier part of our study. And then what is the role of the community? So coming back to one of these quotes, contribute to a collegial and caring atmosphere as much as I can, like be kind, bring treats, and show others that I care. So create that sense of belonging. Going back to self-determination theory, belongingness is really important to feeling whole. And note that relationships with colleagues would account for 6% of our strengths, but also 5% of our stressors. Let's make that all strengths. Let's make that a place where everybody is supporting one another and creating that collegial atmosphere. And then also think about demonstrating and modeling for others. Note that those people who are really burnt out, they don't have good strategies. Those 1 and 2 people, they don't have good strategies to work against some of these stressors they're experiencing. So share those things with people. When you see somebody who's a little bit burnt out, you see somebody kind of at the end of their rope, Think about sharing some of your strategies with them. And this also comes back to Seligman's studies. They found that when they had these dogs in the shuttle box, if they would leash them and drag them to the other side, the helpless dogs, they then would learn to jump to the other side on their own. So sometimes we can show people, dogs or people, how to avoid this. And then lastly, I'm going to talk about the possibility of collective bargaining. So I think it makes common sense to think that unionization for physicians might provide more autonomy and decrease learned helplessness. Okay, no laser beams have come from above. The floor's not open up to swallow me whole yet. So I've said the word union a couple times and I'm safe so far. Let's see if I'm still around at the end of the day. But there are a couple of different studies that looked at this. And unfortunately, the data isn't really there yet. So this study that looked at surgical residency programs, comparing a unionized program to ununionized programs, they did find some improvements in vacation time and housing stipends, but no differences, importantly, in burnout, suicidality, job satisfaction, and other factors. And then a less rigorous study used a Delphi method to compare two different programs and actually interviewed residents, administrators, and physicians. And they found that the resident physician union was identified among the top 3 protective factors in domains of control and fairness. So there's probably something there. I think this really deserves some attention. That's where we go to some of our future directions. So we need to do a detailed statistical analysis of the study we've already done and try to refine our instruments so we can get it back out to maybe a multi-center study and try to validate the tool, which involves a lot more statistical work. And I'd love to then stratify this, looking at what's the effect of a physician CEO at a hospital? What's the effect of having a union? And is this different between a union with attendings or with residents? What's that effect there? As I promised earlier, there is a twist in our story. So remember this guy, Stephen Meyer. So he was one of the original investigators here. And when Dr. Seligman took his turn into positive psychology, Dr. Meyer took a turn and went back and got a PhD, a second one, in neurobiology. And they went back then and studied the neurobiology of learned helplessness. And I think this is pretty fascinating, that they found that the mechanism of learned helplessness is now very well charted biologically, and the original theory got it backwards. Passivity in response to shock is not learned. It is the default. Unlearned response to prolonged adverse events. This passivity, though, can be overcome by learning control. And then I want to close with this analogy of the canary in the coal mine. So you probably know this scenario back when there were a lot of miners. They would take a canary down inside a cage into the coal mine with them because the canaries have smaller lungs, smaller circulatory systems. And if there were toxic fumes developing in the coal mine, the canaries would pass out first before any of the humans. If they saw the canary fall down, they would all leave the mine. And Dr. Maslow wrote a book along with Michael Leitner in 2021 called The Burnout Challenge. And this is one of my favorite quotes from that. Let's say our hope was to keep more birds singing in mines. What would be our best approach? Should we try fixing the canary to make it stronger and more resilient, a tough old bird that could take whatever conditions it faced? Or should we fix the mine, clearing the toxic fumes and doing whatever else necessary to make it safe for canaries and miners to do their work? And I think what we're seeing is it's all the above. We do need to help people. We also need to fix the system. And I've mentioned just a few ways we might be able to do that. And I'm hopeful we can attain some of these in our system and maybe a little more globally. So I want to thank you for your time and attention today. Thank my team, Drs. Romito, Zalman, and McDermott. Special thanks to Dina Hofkosh, who was a wonderful mentor to me and helped me kind of keep this wheel moving forward even after her passing. Katie Forrester helped me think about the statistical analysis here. And then Drs. Dermody, Buchert, Tate, Ray, and Shope gave us permission to disseminate this study. So thank you very much for your time. I'm happy to take questions.